Hello, my name is Joe Phillips. I'm a urology consultant in Bristol. Welcome to the Stones second e-poster session. And I'll let my colleague introduce himself. Will.
So good evening, everybody. My name is Will Finch. I'm a consultant urological surgeon based up in Norwich, and look forward to spending the next half an hour with Joe and taking you through the posters for this poster session. Moving into the first poster, the format Joe and I are going to do is we'll talk about the posters, and we've got a few more things to say about certain ones. But first poster is a nice study which is comparing two lithotripsy machines. It's comparing the Sonolith, which is an electroconductive machine, with a Storz SLX lithotripter. And it's a nice study comparing the two machines, and it shows that there are some differences, and using the same radiographer, using the Sonolith electroconductive machine, there was a statistically significant higher stone-free rate when treating comparable renal stones compared with the Storz machine. A couple of questions I had was whether or not the skin to stone distance was the same for all of the stones. That wasn't clear for the poster. And also what the pain scores for the patients were, and whether patients noticed a difference in the treatment being delivered to them between the two machines. But a nice study comparing outcomes with control for a radiographer, which I thought was very nice. So yeah, thank you for putting that and together, and we'll move on to the next poster, which Joe's going to take us through.
Thank you, Will. The next one is looking at emergency versus elective ureteroscopy for ureteric stones. This is an interesting poster, which is a systematic review and meta-analysis by Al-Sawi et al. From the west of Scotland and Southampton. Looking at, they've screened a significant number of studies and brought it all down to 4 studies with just under 3,000 patients in both studies, with a stone-free rate which is comparable, 85% to 91%. They did have about 3% complications, major and minor complications in the primary ureteroscopy group, with 7%, slightly more complication rate in the delayed ureteroscopy. The stenting was also about 50% only in the primary ureteroscopy, but 70% in delayed ureteroscopy. Being a systematic review, they have not been able to interrogate the individual papers further, but do report on decreased stent usage in primary ureteroscopy, but with higher complications and obviously more cost effective. But it would be an interesting first step for the group to bring this systematic review, and maybe a multi-center trial might be the way forward. I am interested in knowing what the major complications were based on a Clavian-Dindo classification, which is not available. But going forward, this bodes well for a longer study. Interesting paper. Over to you, Will, for number 3.
Excellent. Well, thank you. So the third poster is a study from Portsmouth, which looks at both surgical and radiological factors that may predict stricture formation after the treatment of an impacted ureteric stone. And certainly one of the things that as a surgeon you worry about with impacted stones is that stricture rate. And they've got a 5-year cohort. They identified nearly 300 impacted stones, and they report a stricture rate of 3%. And they went on to do a multivariate analysis. And their predictors of stricture were severe hydronephrosis, ureteric injury, and residual stone post-ureteroscopy. And so I think that certainly fits with my experience of patients who develop strictures. It's always after difficult ureteroscopies where perhaps there is damage to the ureter to clear the stone, or the stone is impacted in the wall of the ureter and it's difficult to clear all the fragments. And certainly that's my feeling. And the question I had really was about their definitions of hydronephrosis and severity of hydronephrosis, but it puts a contemporary up-to-date figure of 3% as a stricture rate for difficult impacted stones. So a nice poster. Over to you, Joe.
Thank you, Will. Now, going on to a well-publicized study, which is the development of a risk calculator to predict spontaneous stone passage in patients with acute urinary colic. A question that we always ask ourselves, and BURST have been quite excellent in generating this study, where they have reviewed over 2,518 patients with a 74% spontaneous stone passage, looked at quite a few predictors, and have been quite robust from a statistical point of view, internally and externally validating it, looking at temporal trends, and coming up with a robust nomogram and developing it into risk calculations. They have identified neutrophil counts, female gender, the presence of hydroureter, the hydronephrosis, a high temperature, stone size, and stone position as significant factors to predict the stone passage. Now, one may ask, so what? But they have moved forward and developed this risk calculator, which will be uploaded on the BURST Urology website. And Chuan Yu Gao has reported back saying that there will be an Android version on the phone app. It reminds me of the prostate cancer prediction Mayo scoring index. So we may have something like that, which may be a game changer for acute ureteric stones. They also hope to develop the risk calculator on a prospective basis for validating this. So congratulations to the BURST group, who have really outdone them, everybody in bringing up a really good study.
Yeah, I mean, I'd agree, Joe. It's an impressive piece of work, and the science with that paper is really nicely done. I thought the spontaneous stone passage rate of 74%. I thought that was interesting. It'd be interesting to know over sort of what time frame patients were given to allow their stone to pass. But that predictive modeler online to be able to identify which patients are going to have a good chance of passing a stone and which ones you may want to intervene with earlier than we might have done historically. I think that online calculator is fantastic, and look forward to trying it out and using it on our patients up in Norfolk.
Absolutely agree. And with the primary urologically paper and the ability to predict spontaneous stone passage, I think we are reaching we're moving forward with these questions that we normally ask, especially when acute stone patients turn up. Yeah.
Excellent. Well, we're going to move forward because the next posters appeared to talk about, and this is a great sort of mix of bench science and mathematics come from Ben Turney and his group at Oxford. And essentially it sets up a bench model looking at renal temperatures during laser lithotripsy, and then it applies a mathematical model to see whether they could predict the bench outcomes using a mathematical equation. And it's interesting, it shows that the maths does predict and does match the bench modeling. And it highlights those things again that we worry about as surgeons in terms of temperature, in terms of flow rate, in terms of laser power, and really the effects these can have on the tissues within the renal collecting system around the stone. So I look forward to seeing really the next step for me is the translation of this into perhaps surgical platforms that will give us feedback about temperature, flow, to sort of really optimize the safety of ureteroscopy for prolonged procedures where we might be using high energy for longer periods of time than other cases. So yeah, look forward to hearing more in the translational side of that.
Thank you, Will. The next poster, which has not been submitted, but the abstract is interesting read, looks at the outcome of ureteroscopic stone surgery and raise the question whether long operating times of more than 90 minutes result in higher risk of sepsis. The authors from the Midlands have reported on 272 cases with Vincent Koo, the main senior surgeon, and have reported on 90 patients who have had the long procedure of more than 90 minutes with 20% stag-on calculi. It is an interesting group, and he reports on the higher pre-op stent rates in the short time group with less mean stone size and lower positive pre-op MSU. So it agrees with what we are all used to when we need more time. Patients usually have infective stones, larger stones, and more likely to have positive preoperative MSU. The Midlands group keep their patients in and have a mean hospital stay of 1.2 days for the short group and a slightly longer mean hospital stay for the longer group. It was interesting to see that there was no increased post-operative sepsis risk in the long group. So it's a shame there's no poster. I would like to have known what their post-operative protocols were. I suspect keeping the patients in and leaving them with a catheter to decompress the system and definitely a stent. But it is interesting that they have reported good results, and I'm quite pleased that we can push the boundaries more.
Yeah, so it's nice to see this. I mean, this complements the ureteroscopy audit that the endourology section did a few years ago under Rob Calvert. And one of the clear messages from that was that after about an hour, the risk of post-operative sepsis went up significantly. So seeing their short group with a sort of median operating time of sort of 3/4 of an hour compared with their longer group where the mean operating time was nearly 2 hours. It's sort of there is a bit of a discrepancy between that registry data from the ureteroscopy audit and their experience. As you said, it would be interesting to see and understand what they've done differently to have favourable outcomes for a longer operative time.
Right. Yeah, I agree.
Lovely. So moving on to poster 7. This is a poster that has looked at infection outcomes for ureteroscopy, and it's a great poster because it really sort of highlights and tries to answer that question of what to do with the asymptomatic patient with a positive urine dipstick or a positive preoperative urine culture. But most importantly, this is focusing on the asymptomatic patients. It's a nice study where they sent off an MSU and a urine dip, which the surgeon was blinded to on the morning of surgery. So the surgeon didn't know what that result was going to be, and they performed the ureteroscopy on the asymptomatic patient. And what they've shown is that there was a slightly, so for patients who subsequently who turned out to have a positive MSU, there was a difference in the readmission rate. It was 7% for the MSU positive group and 2% for the MSU negative group. But that there was a difference, but it wasn't significant. I had an email correspondence with the author about this, and I was interested to know about whether or not they treated any of these patients with antibiotics preoperatively, and none of these patients were treated preoperatively. They simply had standard gentamicin at an induction, and it's important to again make the point that they were asymptomatic patients. So the take-home messages for me are that with the patients who 4 patients developed post-operative sepsis, it wasn't easy to predict which patients were going to become post-operatively septic from these preoperative urine dipstick or preoperative MSU. So for me, the take-home message is that in an asymptomatic patient, it is a reasonable thing to do to proceed with caution with their ureteroscopy. I think it's really important to send off cultures and as much information as you can during the operation, whether that be stone or a on-table MSU, to give you as much information about cultures should they become unwell post-operatively. And it's really interesting to see that actually urine dipstick on the day of surgery really wasn't helpful in predicting who was going to become unwell with sepsis after a ureteroscopy. And I think it's a really great study and really should streamline the workup for patients pre-operatively and on the day of surgery. And it's interesting that if they had been perhaps cautious, they would have had a cancellation rate of 20% unnecessarily, and that's a significant proportion of operative time, especially in the post-COVID recovery era, and a great piece of work to give us the confidence to proceed cautiously and sensibly in operating on these patients who are asymptomatic with a positive urine dipstick or asymptomatic growth on an MSU. What were your thoughts, Joe?
I thought, I agree, but the numbers are quite small to make sweeping changes. And I think this suggests, I mean, like what we have in Bristol is we have a dedicated pre-op assessment unit. All these patients have urine cultures beforehand, and we can treat them ahead of time, but it's not perfect. And the day of the surgery, urine dipstick and cultures are something like, I agree with you that we should use. It's difficult to be able to not treat these patients, but this is the first step going forward. I think it's worthwhile investing in a larger number of patients and looking at what happens with them, because the ability to predict the sepsis.
I think this would be a great study to do on a larger scale, wouldn't it? Because it has real world implications on pathways and utilization. And I think for me, as I said, the take-home message is proceeding cautiously and perhaps understanding whether this data is reproducible on a larger scale outside of the Southwest. But yeah, a nice study, a very pragmatic, nice study.
So moving on to the next poster, which is number 8, it looks at increased infective complications from manual handheld irrigation versus low pressure gravity flow during endoscopic lithotripsy all the way from Australia. It's a retrospective study which looks at 2 groups, overall 234 procedures with similar parameters for age, stone size. And they report that manual irrigation has resulted in increased post-op hypotension, fever, emergency admissions, and post-op UTI versus gravity-only continuous flow. Again, there's no poster and only an abstract, so we don't know the details of the measured pressure, whether the manual irrigation was by an assistant who squeezed the pump every so often, or was it in specific times, such as in the renal helices. It looks like the pressure might have been quite significant because there are systemic inflammatory response appearances post-operatively. It would be also useful to look at sustained pressure rather than just gravity-only continuous pressure, so that we could have compared with, they could have compared with a gentle irrigation rather than just gravity. So a study that has potential, but not much information just yet.
Just interestingly, Joe, what do you use as your irrigation model? Is it gravity fed? Is it a pressure bag, or is it a handheld device? Or
yeah, so we use a combination of gravity and a pressure bag, which is just increased just enough to enable good vision or to dilate the calyces, especially if it's collapsed.
And I think that's the key, isn't it? Using enough pressure to give you a safe view and being very conscious of your pelvic calyceal pressure. And I've anecdotally been involved with some bench tests, and a handheld pressure device can give you a frighteningly high pressure curve. It's amazing how much pressure you can generate. So yeah, it makes the point to think about what you're doing and how you're doing it. Lovely. Well, moving on to the next poster. Again, no poster available to view, but an abstract. And this is reports on a piece of work that's been done trying to get an international consensus on how we talk about and how we report and how we classify PCNL. And there's a number of people who've been involved in this from around the world. And I think what they're trying to achieve is absolutely where we need to be and going forward with PCNL research. They've suggested a criteria for conventional PCNL being above 22 French, and for miniature PCNL being below or equal to 22 French. They suggest that the position, i.e. supine or prone or lateral, should be stated at all times. And they've come up with a number of other classifications that they feel that are important as well on a sort of on a graded scale. I think we're all in agreement that going forward, we all need to be talking the same language and reporting in the same parameters with PCNL, so we can compare apples with apples rather than apples with bananas or pears, which is often what happens in the literature. So it's nice to see joined up thinking, and I look forward to us reaping the benefits of it in the literature going forward.
Yeah, I agree with you, Will. There's quite a few factors they've put forward, and whether that will meet with wider acceptance, only time will tell. So moving on to number 10, the efficacy and safety of EMS Swiss lithoclast trilogy for PCNL, a European multi-center prospective study on behalf of ESET. So a 10-center study looking at the efficacy and efficiency of the lithoclast trilogy. And the authors have had 157 patients and looked at the stone clearance and the efficiency and efficacy. They report a stone clearance rate of quite good number, 65 millimeters squared per minute, which is indeed quite significant. They also talk about better suction effectiveness and better ergonomics, which are things that we are looking forward in modern equipment to enable change. They have reported on a 9.5% complication rate, Clavin Dindo 3 and 2, which may not necessarily be associated with the technology, but more so with the patient population. And it would have been interesting to know what sort of lithotrites they had used before to see such traumatic benefit. And I think, Will, you've been also involved in this. So the calculated 3D stone volume would be something to know about. And I accept the author's conclusion that breakage may be to do with learning curve. But it's an interesting paper, especially with something new for PCNL.
So I think it's really nice to have had the opportunity to use Trilogy and be one of the early centres to use it, but also to do this collaborative piece of work and put some data against actually what the machine has provided. Certainly with the stone volume, I mean, there's heterogeneity across the centres. Some people are fortunate enough to have calculated 3D stone volumes off CT, and for others, and certainly our experience in Norwich, it was measurement and then putting that into a mathematical model to generate that data. Certainly with cases, it was all comers for us. It was the only option for conventional PCNL and a couple of mini PCNLs actually. So all cases, and it's my experience is that it is efficient, very, very efficient. But we were coming from having used kit that hadn't really worked for us previously, so it was a huge step up for us and a good experience. And as you say, it'd be interesting to compare and contrast that with other comparable pieces of kit on the market. And the breakage rate, I think there is a learning curve to that, but certainly there is, across the centres that was mirrored, and it may be a reflection of the early ones on the market, and things may change, but it works very well. Pleased with it.
Overall, it's very difficult to conduct multi-center trials, especially when equipment is involved. So that was a well done study. Thank you.
So moving on to this next study, which is come from Nottingham, and Harry and Sharon Scriven and their group, looking at PCNL in the elderly, and they've defined elderly as over 70, and this is a retrospective analysis of 43 procedures in 40 patients. And they report a stone-free rate of 65%, and they had a length of stay of 2 days. And they report on their complication rate with a transfusion rate of 2.5%, and stone type similar to the under 70s. And I thought this was a nice study, and it complements a PCNL registry piece of work from about 5 years ago, looking at PCNL in the over 80s. And they've shown a different experience, and that with less complications, whereas the BAUS data showed that the over 80s have more complications and a longer length of stay for less complex stones. And I think that may well be, it'd be interesting to know whether Sharon and Harry think that's a reflection of doing predominantly mini PCNL, and we're really seeing the advantages of mini PCNLs, particularly reflected in this older patient group. But it's nice data and should encourage people not to avoid doing PCNL in older patients when it really may be the best operative option for them.
Yeah, thanks, Will. Also, their Charlson comorbidity index was only 4, suggesting these were really fit and healthy patients. So whether all comers should be reported on, like you said, over 80s. Standard PCNLs, it would be interesting to know whether we should use different risk profiling, such as using BMI, UTI, stone burden, other just things like Charlson comorbidity index, but a step in the right direction, I agree.
Yeah.
So the next study, again, there is no poster, but Simon Chung did reply to my queries. So this is a comparison of super mini PCNL and standard PCNL for kidney stones, a 14 French super mini. And they have gone up to 70 millimeters and looked at patient and public involvement and quality of life data. So an interesting study, because the European Quality of Life questionnaire that they have used looks at mobility, self-care, usual activities, pain and anxiety, and they've also reported on the index. They had quite significantly good results, 88% stone-free. Of the 50 patients that they undertook super mini PCNL, 5 of them had more than 2 centimeter stones. 78% were totally tubeless, and 66% stayed less than 24 hours. So really great practice, good results. And Mr. Chong had reported back saying that most of the stones were in the lower calyx with an acute infundibulopelvic angle. So similar characteristics to what we would normally use. And the standard PCNL comparison was with patients who've had standard PCNLs within the last 10 years. What is interesting is, since he submitted the abstract, he has gone on to use the same technique for larger and staghorn calculus, and reports that the thulium fiber laser seems to be the way forward and has made him able to take on larger stones. So thulium fiber laser at 60 watt. So the interesting development, and sort of confirms the new kid on the block with the thulium laser.
Excellent. Well, I think it's great to see people, putting new technology against and seeing where it can really benefit, and reporting back through BAUS and meetings like this as to, what's helpful and what's highlighting good practice. So the next poster is poster 13, and this is a single center study reporting on their experience with mini PCNL, and they're using the Stort's MIP-M set, which is a 12 French nephroscope and a 16.5 French sheath. And certainly this is the PCNL mini PCNL kit that I'm using. They reported, which I thought was nice, on their drainage outcomes. 37% of cases used a stent, 45% of cases had a ureteric catheter overnight, and nearly 20% of cases being totally tubeless. They performed their patients supine. We're getting good stone-free rates, no transfusions, a length of stay of 1.3 days, and an overall stone-free rate of nearly 90%. So I think it's a nice study, clearly demonstrating that with mini PCNL and that Stort's MIP-M set, that you can have good outcomes, and encouraging people to have people with totally tubeless or very, very short post-operative drainage overnight potentially, and then home. So nice outcomes.
Agree with Will. I think we are moving towards miniaturizing techniques and technology, using better lasers, and hopefully leading on to day case PCNL in the not too distant future. The next abstract and poster is, I think there is one before, which is poster 14. Yes. So, yeah, we are looking at, this is an innovative idea, and Professor Rasa reported that one of the reasons for bringing this change into his practice was the delay in getting nephrostograms following PCNL. So the poster is on Foley catheter nephrostomy post-PCNL, a simple way to reduce inpatient hospital stay, radiation exposure, and cost to the NHS. So they've used a Foley catheter instead of a nephrostomy, ranging from 12 French to 16 French, provided they can get into the renal pelvis. So the infundibulum is wide enough to enable this. And they report back that in about 150 patients, where there were about 90 pre-Foley and 64 post-Foley, there was an inpatient stay reduced to 2 days from 3 days. And he's reported back that this is probably from the delay to getting nephrostograms. So a good innovation within the limits of the capability of a hospital. One of the downsides of this technique is that you don't have Foleys suitable for mini perks. So, but definitely better innovation, not needing fluoro to remove a nephrostomy if there is a stent. So moving forward techniques. Thank you.
Great, and moving on to the last poster, which is a nice poster looking at the role of ultra low dose CT, and we're all very conscious about the fact that we realistically are imaging more and more patients with CT, and really how we can mitigate that by reducing the dosage of those CTs. And this was a nice study that looked at ultra low dose CT. And what was interesting for me was that their dosage report for the ultra low dose CT KUB was actually lower than their plain abdominal film, which is really impressive. And the ultra low dose CT pelvis dose, albeit lower than their ultra low dose CT KUB, it wasn't that much lower, but no, a nice study. And so they concluded that they've significantly reduced their radiation dose by using ultra low dose CT. And one of the concerns with low dose is that the scans are uninterpretable, and actually it hasn't, makes the clinical decision making difficult. but they had a nice way of sort of checking reporting, and only 2% of scans were initially considered suboptimal. And then when they were looked at by uroradiologists and re-reported or collaborative reporting, things became clearer. Interestingly, BMI wasn't recorded in the audit, and so it'd be interesting to know whether that would have had effect on those slightly more difficult scans. Often it's a very low BMI and not enough intra-abdominal fat to actually to differentiate between tissue planes that I've found difficult when looking at these low-dose scans. But I think it's studies like this should really really empower us to understand what our dosage rates are for local imaging, and really trying to adopt and drive our radiologists in your centres to use low-dose protocols where at all possible. Because, you know, I don't know what your feeling is, Joe, but I think we're using more CT because we want to know whether patients have stones or have passed stones, or whether we need to intervene because their stones haven't progressed. And ultra low dose CT has got to be the future for helping with that.
I agree totally. Well, because we're seeing quite a few patients coming in with 3 and 2 millimeter stones obstructing, and the tendency has moved from presuming that these stones will pass to making sure. So we are doing definitely more CT pelvises, and I think it would be interesting, as you said, to look at interpersonal variability, to look at the BMI, and also the comparison with the phlebolytics, which is a notoriously difficult thing to rule out or rule in.
I did try, unfortunately, I didn't hear back from the authors with some questions, but they talk about iterative reconstruction, and it's also the time that takes the radiologist to do that, and how much time that adds to their working day. And actually interesting is sort of what the radiologists prefer, whether they find it's a bit more of a fiddle and longer to report these low dose scans compared with standard. But, you know, again, nice to see some UK data against an everyday conundrum that we all have as stone surgeons. So that's all I wanted to say about that final poster. But I thought, Joe, I thought the standard work that had come through, there's a lot of hard work, a lot of good projects going on around the UK, and it's fantastic to see them showcased in a poster session like this. Certainly, for me, the highlight poster was the burst piece of work looking at spontaneous stone passage, poster 4. Very good science, as you quite rightly demonstrated. Anything to add, Joe?
I agree. We've had some really good studies. We've had clinical studies, bench studies, and a lot of food for thought. And I hope the people joining this session will take home a lot of learning points. And I concur with you that the burst study is going to be a game changer, big numbers, statistically robust, and the fact that they're going to bring forward apps for us all to use, to be able to then predict which ones can be given some time to allow them to pass stones, where against trying to enable primary ureteroscopy, will help us, especially in this COVID times. And I think that's
a big
really
step
great
forward,
study.
and trainee-led, which is fantastic.
Yes,
so,
absolutely.
Fantastic, Joe. Well, it's been a pleasure working with you, Joe. Thank you very much.
Likewise, Will. And
everyone, it's a first for Joe and I, a virtual poster session. I suspect it won't be the last, Joe.
Nice. Thank you again.
All right. Take care. Thank you.
You too. Bye. Thank you, everyone.